Good day, dear colleagues. I'm Natalia Oleynik. I'm professor of surgery department of Belgorod State University. My authors, Irina Krivchikova, Andrei Yarosh, Natalia Bartisheva, and me, we are going to bring to your attention the results of our study on the topic of disorders of pelvic floor innervation and its surgical correction in patients with perineal prolapse. The study was performed on the basis of coloproctology department of Belgorod Clinical Hospital of St. Iosaf in Russia. In most women with pelvic organ and perineal prolapse develops so-called perineal descending syndrome. For the first time, it was discovered by Parkes as long ago as in 1966. In 1985, Henry Swoosh published the monograph Coloproctology and the Pelvic Floor. However, even today, pelvic floor pathology is still far from its solution. Pelvic prolapse is one of the leading medical problems affecting women of all ages. Analysis of the literature data shows that the prevalence of this pathology increases with the age and is 48% in women of 50-60 years old and 50-60-80% in women over 60 years old. The development of pelvic prolapse depends on many factors, the main of which are childbirth, age, and increase in body mass index. These factors lead to an increase of intra-abdominal pressure and later to the dysfunction of the complex of muscles that raise the anus and pelvic ligaments and as a result to descending of perineum. Hereditary predisposition presenting in connective tissue weakness. The main manifestation of perineum descending syndrome is obstructive defecation, which is characterized by difficult evacuation of the fecal masses from the rectum and the need for prolonged strong straining. With the perineum descending, rectocele, rectal mucosa prolapse, rectal intussusception, and interocele may be developed and increase the symptoms of the disease. Obstructive defecation significantly reduces the quality of life of this category of patients due to the need to spend a lot of time in the toilet, the feeling of incomplete emptying of the rectum after defecation, the need to use laxatives and cleansing enemas. The pelvic floor is formed by muscles, fascia, and ligaments interconnected with each other and the bones of the pelvic, forming the single anatomical space. The functions are regulated by central and peripheral nervous system. The peripheral nervous system supplies the pelvic floor with branches of the sacral plexus. The sacral nerve goes down to the pelvic floor. Despite the fact that anatomically this area is sufficiently studied, the neurological and biomechanical functions of the pelvic floor are not well understood, and knowledge about them is constantly evolving. Obviously, the normal anatomy of the pelvic floor is fundamental to the physiology and this complex anatomical area. In some patients with perineal prolapse, excessive straining during defecation can lead to neuropathy of the sacral nerve. The neuropathy of sacral nerve progresses with an increase in prolapse. This leads to dysfunction to the pelvic floor muscles and exacerbates problem with emptying and retention of intestinal contents and sometimes to its incontinence. Perineoplasty with native tissues, including posterior colporrhaphy and anterior and posterior levatoraplasty, has been proposed and widely used to correct rectocele and perineal prolapse. However, literature notes their insufficient effectiveness and short relapse-free period. The most effective way to correct the prolapse of the rectal mucosa is currently stapler transanal resection (STAR), but the technique does not allow you to correct the level of the perineum location. For the surgical treatment of pelvic organ prolapse, abdominal sacrocolporectopexy using a synthetic graft has been widely used in recent years. However, data on its effectiveness in relation to the correction of perineum prolapse are not available in the literature. Thus, to date, no effective method has been developed for the surgical correction of perineal prolapse, especially combined with rectocele and rectal mucosal prolapse, and there are no guidelines for the treatment of these disorders. In view of the above, we conducted a study aimed at improving the results of treatment of perineal prolapse syndrome in women. The immediate and long-term results of surgical treatment of perineal prolapse syndrome using sacrocolporectopexy were studied in comparative aspect with the results of perineoplasty. In contrast to the methodology proposed by de Hoor for the treatment of the rectal interception, which placed a mesh graft between the anterior wall of the rectum and the vagina, we used additional two grafts and placed them along the anterior wall of the vagina and posterior wall of the rectum, as shown in the above diagram. In patients with rectal mucosal prolapse, sacrocolporectopexy was supplemented with the STAR technique. For prolapse diagnostics and monitoring the course of postoperative period, the following procedures have been performed: dedicated questionnaire, digital rectal and vaginal examination, rectoscopy with training according to Parks, difficography, ultrasound and magnetic resonance imaging, anorectal function tests. Anamnesis collection was performed using the validated King's Hair Questionnaire, the Cleveland Clinic Constipation Scale, and the Wexner Incontinence Severity Scale. Difficography has been performed for determination of perineum level relative to the pubic coccygeal line, the value of the anal rectal engine, as well as degree of severity of rectocele and the presence or absence of the rectal mucosal prolapse. Intrarectal and transperineum ultrasonography gave the feasibility to see pelvic floor muscles, rectovaginal septum in the norm in case of its atrophy and rupture, and also to visualize the synthetic graft and the correctness of its location in the post-operative period. MRI made it possible to visualize all the structures of the pelvis and pelvic floor simultaneously and in different planes. No invasiveness and absence of radiation during ultrasound and MRI allowed using them an unlimited number of times in the same patients for monitoring after surgical treatment. Assessment of the rectal continence function before and after surgical treatment and evacuation function were performed using physiological research methods, manometric and electrophysiological. They were performed on a stationary computer multifunctional unit for assessing the function of the gastrointestinal tract, polygraph ID, company Medtronic. Anorectal manometry was performed using water perfusion system that includes a perfusion pump, an external pressure converter, and IBM-compatible personal computer. In this case, multi-channel pressure centers with longitudinally and radially arranged registration channels were used. Anorectal manometry was performed with continuous stretching of the catheter at a constant speed along the anal canal, so profilometry was performed with computer data processing. The pressure in the anal canal was recorded at rest, the function of the internal anal sphincter, with volitional contraction of the pelvic floor muscles, the function of the internal anal sphincter and puborectal muscle, as well as with external influence of introduction the air into the rectal balloon, the inhibitory reflex of the internal anal sphincter to stretch of the rectum. A cough test to make sure that the external anal sphincter contracts in response to a sudden increase in intra-abdominal pressure. The sensitivity of the rectum was also evaluated. The first sensation, i.e., the ability to feel the small stretch of the rectum in small volumes of the maximum tolerable stretch. The results were evaluated using a volumetric mathematical model of the distribution of the anal pressure vector or using graphs of the pressure distribution along the circumference and length of anal sphincter. To study the process of defecation, a simple and informative balloon injection test is often used. A balloon is placed in the rectum and filled with water. Sitting on a makeshift toilet, the patient must hold and then push out this balloon. Normally, a person can push out a 50 milliliter balloon without much difficulty. Electrophysiological methods are used to study the electrical activity of the pelvic floor muscles. Electromyography allows you to diagnose disorders of its innervation. To register the electrical signal from the muscles, various peripheral sensors, cutaneous, needle-like, intraanal, are used. The electrical impulses received from them are recorded on various modifications of electromyographs with subsequent computer processing of the information. Time characteristics are also recorded when the muscles are stimulated by electrical impulses before a reflex response is received, i.e., the latent period of the reflex. The method is often used to study the latency of the sacral nerve in incontinence of intestinal contents and urine, since one branch of the sacral nerve innervates the striated periuteral muscles, the other the external sphincter of the anus. To study the activity of the latent period of the sacral nerve, an electrode of St. Mark's Hospital is used. The nerve is stimulated on each side. At the same time, the reduction of the external anal sphincter is noted by the characteristic changes in curve of the recording device. Terminal motor activity is the fastest response of the muscle by contraction to nerve stimulation, the contraction of the external anal sphincter. Thus, for the diagnosis of various pathological conditions of the perineum, patients should currently undergo a comprehensive examination. The continuous technical improvement of these research methods in the basis of the development of knowledge in this field and serves as a tool for the further improving the results of providing medical care to patients with anatomical disorders and diseases of this complex anatomical and functional area. The criteria of the evaluating the results of surgical treatment were frequency of intra- and postoperative complications, the degree of anatomical correction of the position of the perineum, rectocele, rectomucosal prolapse, normalization of the rectal emptying function, restoration of the function of halting intestinal contacts in patients with existing incontinence. We studied the immediate and long-term results of surgical treatment of perineum descending by sacrocolporectopexy combined with star procedure in a comparative aspect with perineoplasty, with additional flap excision of rectal mucosal prolapse in patients with its pathology. The sacrocolporectopexy group consists of 52 patients. The perineoplasty retrospective group consists of 48 patients. Both groups were homogeneous and did not differ significantly in demographic indicators and the presence of concomitant pathology. Our study have shown that 47% of patients with perineum descending have rectocele, 23% of patients have rectal mucosal prolapse, and 30% of patients have a combination of rectocele and rectal mucosal prolapse. All patients had obstructive defecation, and 60% of patients have stage first or second of intestinal incontinence. The frequency of combined pathology in patients of two groups is presented in the table, which shows that the comparison groups did not differ in the nature of combination and severity of the pathology. Studies have shown that the number of complications in the sacrocolporectopexy group was 10% lower than in the perineoplasty group. The spectrum of these complications was different. In the first group, they were more often associated with mesh implantation. In the second group, purulent inflammatory complications prevailed, and dyspareunia and pelvic pain were also more frequent. When evaluating the anatomical results, it was found that rectocele was corrected in patients of both groups and after 6 months corresponded to 0 or first stage. In most patients of the sacrocolporectopexy group, the results were preserved after 3 years. In the perineoplasty group, the size of the rectocele increased and corresponded to the first or two stage. Also, in both groups, it was possible to achieve a rise in the perineum to an almost normal level. However, after 3 years in the perineoplasty group, the results worsened. Also, they were better than before the operation. The values of the inner rectal angle, which significantly exceeded the normal values before the operation, decreased to the almost normal values in both groups after 6 months. In the long-term follow-up period, a gradual increase in this parameter was again observed in the perineoplasty group of patients. In the patients of the sacrocolporectopexy group, it did not worsen in terms of follow-up. Prior to surgical treatment, the evacuation function of the rectum was reduced in patients of both groups. 6 months after the operation, the rate of barium evacuation in patients of the sacrocolporectopexy group was higher, and the amount of barium remaining after emptying was less. The achieved results were maintained longer than in the perineoplasty group patients. In X-ray confirmed upper rectocele, the severity of apical prolapse was assessed by MRI in 13 patients of the sacrocolporectopexy group and in 10 patients of the perineoplasty group. In this category of patients, the uterocervical zone at rest and when straining was below the level determined in women with a normal pelvic floor position, and its mobility exceeded the norm by 1 centimeter. After 6 months of the surgical treatment, the patients of the sacrocolporectopexy group showed normalization of the location of the uterocervical zone relative to the pubococcygeal line, which did not change after 3 years. In the perineoplasty group, apical prolapse persisted after surgical treatment and gradually progressed. In the post-operative period, there was a gradual recovery of the continent function in the patients of both groups, but to a greater extent in the sacrocolporectopexy group, which was confirmed by the pressure figures in the area of the internal and external anal sphincter. Despite the unreliability of the differences between these indicators, in the patients of the sacrocolporectopexy group, they were higher and did not significantly differ from the norm. This fact, like other authors, we associate with the cessation of overstretching of the sacral nerve as a result of the fact that the perineum occupies its normal anatomical level and stops prolonged straining during defecation. In our work, this is confirmed by a decrease in the latency period of the sacral nerve. So, perineum descending syndrome in women is manifested by various anatomical and functional disorders, which for the most part occur not in isolation but in a combined form. Currently widely used perineoplasty, including posterior colporrhaphy, anterior and posterior levateroplasty, allows to correct the rectocele to a greater extent, but not the level of the perineum location, which leads to unsatisfactory functional results of treatment. In patients with upper rectocele, the technique does not allow the correction of the apical prolapse of the vagina. Abdominal sacrocolporectopexy using a synthetic graft is an effective method of correcting perineum, as well as rectocele in this category of patients, while providing apical support to the vagina. In patients with rectal mucosal prolapse present in combination with perineal prolapse, there is no correction of mucosal prolapse during sacrocolporectopexy. In this combined pathology, additional excision of the excess rectal mucosa by transanal access is necessary. Stapler transanal mucosal resection (STAR) is an effective method of eliminating this pathology and leads to improved anatomical and functional results of treatment. It is expedient and possible to perform abdominal sacrocolporectopexy and the STAR technique simultaneously, which avoids multi-stage treatment of patients with perineal and rectal mucosa prolapse and improves their quality of life. Thank you for attention.